Welcome to our third and last lecture of the 2024-2025 Distinguished Faculty Lecture Series. My name is Fahd Abdel Khaliq, I'm Provost, and I want to start by saying that Chancellor Reyes apologizes for not being able to be here today. He's down in DC with a delegation, advocating for some of the few things happening, so he just sends his apologies. Thank you for joining us today for this distinguished faculty lecture titled Building Strength from Within, Engaging Refugees in Designing, Implementing, and Evaluating Strength-Based Mental Health Interventions to Reduce Stress, Anxiety, and Depression. Today's distinguished faculty lecturer is Kaplana Podel Tandukar, who's professor in the Elaine Mereb School of Nursing. So before I begin, I just want to tell you how this will work. I'll eventually introduce Dean Vorderstrasse to say a few words about our distinguished lecture speaker here. She will deliver her talk, and then we'll have a few minutes for Q&A, and then I will present on behalf of the Chancellor, the Chancellor's Medal to our distinguished lecturer, which is the highest honor that UMass Amherst gives to our faculty. I also want to let you know that there's a recording of this session that will be available for you to view at a later time. Now it is my distinct pleasure to introduce Alison Vorderstrasse, our Dean of the Elaine Mereb College of Nursing. She joined the campus as Dean in 2020, and since then she has grown the college's clinical presence in the community and found ways to improve access for underrepresented students. She has been incredibly instrumental in securing significant philanthropic support for this school and doing a lot of great things. I want to tell you that Dean Vorderstrasse is a very strong advocate for both the Elaine Mereb School of Nursing and for the communities, and she's an amazing partner to me and to the Chancellor. So without further ado, Alison, would you please introduce our speaker?
It's my honor and pleasure to introduce our distinguished faculty lecturer speaker today, Dr. Kalpana Podel Tandukar. She has been a highly regarded member of the faculty of the Elaine Mereb College of Nursing for 10 years. She has earned multiple degrees in Nepal that provide her with a strong and diverse background across public health, sociology, anthropology, and medicine. She has a PhD in international health from the University of Tokyo, Japan, followed by a 3-year postdoctoral fellowship in clinical epidemiology at the National Center for Global Health and Medicine at the University of Tokyo. She brings this incredible breadth of expertise to her teaching, research, and service in the College of Nursing and beyond our campus, making her a very relevant candidate for this distinguished lecture series. Dr. Podel Tandukar is an exceptional global public health researcher, educator, and mentor. Her research has impressively and rapidly expanded from internally funded pilot work to well-funded, community-based translational science, addressing mental health inequities among immigrant, refugee, and older adult populations. The most highly cited and regarded part of her work and in her research and engagement is that she truly takes a community-based participatory approach to her research to identify needs, develop interventions, and integrate active community members throughout the research process in a train-the-trainer model to broaden the community impact of her research. She was recognized for this exemplary research as a recipient of the UMass Distinguished Community Engaged Researcher Award in 2022, as well as for her excellence in mentoring other faculty as a recipient of the 2024 Advanced Faculty Mentor Award. Her research has been funded through multiple successful internal and external grants over the years, including those from the National Institute of Mental Health, the Blue Cross Blue Shield Foundation of Massachusetts, and the Massachusetts Department of Public Health. In summary, her engagement and impactful research within many communities in our region and beyond is exemplary. She is sought after for this expertise, and sharing it through this distinguished faculty lecture series is in line with our university's mission and drive to increase our true community partnerships and mutually beneficial relationships. To quote Chancellor Reyes, since he couldn't be here, Dr. Podel Tandukar brings the community to UMass and UMass to the community. Please join me in welcoming her to provide her distinguished lecture entitled Building Strength from Within.
Thank you so much. Thank you so much, Dean Borderstres, for my warm introduction. And good afternoon, and thank you so much for joining my talk this afternoon. So today I'm so much honored and pleased to be here to present our community-based participatory research work that we have initiated since 2015 and to show the impact of our program not only on the mental health burden but also on so many different social and economic aspects. So today I'll be focusing my talk basically on two aspects. The first one is we are going to focus on the community engagement aspects that we have initiated from the very beginning, from the need assessment, program development, program implementation, and program evaluation and dissemination. And after that, I'm going to present about the impact of our program to reduce stress, anxiety, and depression among Bhutanese, Ukrainian, and Afghan community members. So that we do have lots of evidence that have shown that mental health burden is so high among refugees and immigrants resettled in the United States. So the lots of different traumatic experiences and everyday stresses during and after migration contribute to the greater burden of mental health burden among immigrants. And besides that, the everyday stressors related to their daily life also give heavy toll of mental health burden among them due to lack of language efficiency, social isolation, and the lack of social support and all lots of other different sociocultural skills required to adjust in the new sociocultural environment of the United States. And so because of all these reasons, the mental health burden is very high among refugees and immigrants living in the United States as compared to the general population. So we do have lots of mental health intervention that is so much helpful to reduce the different social and economic impacts among different populations, but unfortunately, the refugees and immigrants, they underutilize such services. So because of that reason, we really need the community-oriented, culturally tailored intervention that will be helpful to address their social and emotional needs of diverse population. So basically, we founded our project based on this gap to build up this gap. Built up this gap, we founded this for our project basically with three different aims. The first one is it all right? Yeah. Our first objective is we identified the community stressor and the protective factors in year 2015 and 16. That's how we started. And after that, we identified the protective factors, and we designed the intervention by incorporating both the community stressor and the protective factors. And after that, we designed pilot test intervention, and we evaluated. And then after that, currently, we are replicating our intervention in the various group of refugees from Bhutanese, Ukrainian, and Afghan communities. So at the first, we started our project from the Bhutanese community, mainly because of three different reasons. The first one is the Bhutanese refugees are one of the largest group of South Asian refugees resettled in the United States in between 2008 to 2012. Around 90,000 Bhutanese refugees were resettled at that time. And besides that, at the nationwide, as well as statewide also, the data suggests that the mental health burden is so high among in these populations. Just like the CDC data in the nationwide, it shows that the suicide rate was 21.5 per 100,000 population, and at the same time, depression symptoms was 20%, anxiety 19%, and the psychological distress 17%, and which is much more higher than the general population. And at the same time, we also did pilot study in the Western Massachusetts, particularly from the Springfield, West Springfield, and Westfield by recruiting 226 participants. So in our survey also, we found that the depression symptom was quite high, around 24%, and anxiety 34%, and the perceived stress is 38%. So having both statewide and nationwide, the burden is also so high, and the number of population is also wide bay. And besides that, I do share their culture and the language, their culture and then language. I also speak the Nepali language they do speak. So this is also one of the biggest strengths for me to work with this population. And then another big coincidence is I worked with this population as a clinician back in 1992 when they were first resettled in the refugee camps in Nepal. So I'm so much glad to be connected with this population in 2015 after so many years and work with this population. So at the first step, we explored the community needs by spending so many times, so many months interacting with them to know their new life in the US, how they are doing their life, what are their health problems, what are their health-seeking behavior, and what are their needs, and what are the support system do they have. So after having lots of conversation at the different level, at the both formal and informal settings, we ended up on working mental health problem based on their need and demands. So these are some of the pictures of conducting meetings in our community setting to identify the needs. So after that, in the second step, we train our community members in conducting the qualitative research. So we hire different group of community members, and then we orientate them in the IRB process and in our research procedures. And we also requested them to complete the CT training to start working on the research project. And after that, we train them in the qualitative research procedures, including like a participant recruitment, conducting focus group discussion, documentation, dissemination, and as well as to develop the guide questions as well. So once we train them, then the trained community researchers, they conducted focus group discussion, 8 focus group discussion by recruiting wide participants from different Springfield, West Springfield, and Westfield areas. And then they conducted the focus group discussion, and then they collected their own voice by exploring what are their needs and what are the support systems do they have. And they also transcribed the collected information, and they also participated in disseminating the study findings by publishing in the international peer-reviewed journal. And especially at the time of dissemination, they greatly contributed the importance and significance of findings for their community, and that is the greatest strength. We could incorporate their thoughts and feelings in our findings. And after that, in the next one, we trained another group of community members in conducting quantitative research. So in this one also, they completed the CT training, and we gave them all the orientation about the quantitative research process, IRB procedures, and we trained them in collecting the survey data collection procedure, participants recruitment, and as well as collecting the survey data and documentation and dissemination. So these trained community research assistants, they conducted surveys for our multiple projects. Just for our first project, they conducted survey on 226 participants, in our second 103, and in our third project 232 participants by they visited, and then collected information by visiting participants at their family level. And after that, they were also trained to take the here and near sample to measure the cortisol level, and they also measured the height, weight, blood pressure, and the pulse from all the participants. And after that, they also co-author in all the publications by giving their significant contribution on the meaning and interpretation of the findings. And all the undergrad students of our UMass Amherst help us to enter the data. So altogether, we collected wide variety of information. We collected first group of dietary measurements, and we collected information on different macro and the micronutrients. And another factor, we collected information on the different sociocultural, demographic, and economic factors, and different social support and networking factors. And the third one is we measured the stress marker by collecting the nail and hair samples. And we measured the association between all these independent variables with our outcomes on stress, anxiety, and depression, and the suicidal ideation. So these are some of our publications we co-author with our community collaborators. Just in our first paper in the coping, we found that the problem and the emotion-focused engagement coping was highly protective to reduce the stress among refugee population. So in our next publication, in our resilience, we found that higher the resilience level is more protective to reduce depression and anxiety. And in our qualitative paper, in the third paper, we found that community members were so much optimistic and resilient, and they are so much eager and excited to learn different skills so that they can have better, they are so much better equipped to adjust in the different new and different cultural settings of the US. And these are the findings. And we are so much thankful to our UMass Amherst for funding all this support to conduct all these baseline studies. So after that, we presented all these findings to the community members, and we presented the different findings on the social stressors, protective factors, and emotional stressors. And then jointly, we worked with them together to identify the different intervention components that might be helpful to address their need. And we listed different interventions, just like within the problem-focused coping, we listed different coping skills, social networking skills, and stress management skills. And in emotional-focused coping, we mentioned different mind-body exercises and meditation and all those components. So these are the list of components they came up with, and we prioritized based on their need and demand. And after that, we correlated these intervention components with the 3 best evidence-based intervention, such as behavioral activation, psychoeducation, and the mind-body intervention. And finally, we included this intervention in our social and emotional well-being intervention. And basically in our intervention, we have 5 different models. The first one is the stress management and the mind-body exercises. And second component is how to promote the inter- and intracultural communication skills. And the third one is the cross-cultural social networking skills. And fourth one is problem solving. And the final one is create a healthy family environment. So these are the 5 different basic models of our intervention. And we tailor these intervention components based on the need of the different refugee populations. And basically, these are the 2 hours intervention. And we used to deliver 1 session of intervention every week. And theoretically, our intervention is guided by 2 basic theories. The first one is Lazarus and Folkman stress and coping theories, and second one is Bandura's self-efficacy and social cognitive theories. So according to this theory, our intervention aimed to reduce stress, anxiety, and depression by improving coping strategies, self-efficacy, and other social support and social networking skills. So while delivering the intervention, we have like a 2-hour session. In the first hour, we used to deliver the health education component on the stress, communication, and social networking, and the problem-solving exercise. And they used to make a weekly plan for their problem-solving exercise in which they need to practice. And in the second hour, the participants greatly enjoyed 20 different type of different mind-body exercises component. And these are the samples of some of our intervention materials, especially the first one, how stress affects the body. All the community members from the 3 different refugee populations, they really like this these reading materials, and these materials really help them to remember that how much the stress is dangerous to our health, and that inspired them to take different stress management strategies, to take stress management skills for them to reduce the stress. And the second one is we made the different type of the tips, and that they think like that will be helpful for their community. And the participants are allowed to choose 1, 2, or 3, whichever the number they feel comfortable to pick up from that tips, and then they can practice every week. And the third one is examples of our practice exercise sheet. In this one, they used to make a weekly time plan for the stress management skills, and then they do every week in every 5-week duration. And this is for the stress component, and similarly, we made all the materials for the other 4 components also in the similar pattern. And these are the examples the community participants they prepare. These are the examples of the weekly plan they prepare for their stress management and the problem solvings. And this is the pictograph we prepare for the mind-body exercise. Especially this population, they really love seeing pictures and working together instead of going through the internet and computer, those type of stuff. So we prepared this type of pictograph, and then the field supervisor, they told us that they were hanging these pictures in their refrigerator in their room so that they can practice this type of exercise together with their kids and family members. So with this, and after we developed this intervention, then at first we implemented this intervention in the group-based intervention one, and for this one we recruited participants from Springfield, West Springfield, and the Westfield, and we implemented 5 different sessions, and then we measure mental health, social and emotional stressors, and then behavior before and after the intervention to see the impact of the program in this community. And these are some of the pictures of the community members enjoying our mind-body exercises. And our quantitative data shows that the prevalence of anxiety and depression reduced more than 50% after the intervention. So this is a huge success of our program, of our pilot study. So with having this success, even the community members, leaders, participants, and all of us, we became so much excited to scale up that intervention at the community settings. And after that, we designed our intervention for the family settings. And to implement the program at the family settings, first, we recruited a group of community members. We invited them in our UMass Amherst, and we trained them to deliver all those 5 models of intervention components in their community settings. And so at first, we designed 5 full days intervention for the community interventionists. And after that, those trained community interventionists, they implemented program in their family settings depending on the participants' available time. So these are some of the pictures. Our trained community interventionists, they are delivering intervention to the families. So in this project, they reached out to the 50 families by including 103 participants for the survey. But at the same time, in this project, they were covering 103 participants as well as all of their interested family members, because they also joined these interventions. And for this result also, in this study also, we found that our anxiety, stress, and depression, all of them reduced more than 50% in the post-intervention as well as in 3-month post-intervention. And besides that, our other like coping, social support, social networking also, it has shown that it has been widely improved after the intervention because our mean scores of all those measured parameters increased from pre to post-intervention. And these are some of the community voices on our program benefit. They mentioned that the community engagement approach of the program brought shyness in the community and brought more openness and connectedness among each other. And most importantly, we got an opportunity to share our knowledge and skills with our family and community members, which made us more confident and self-reliant, and we feel more valued in our society. This is their sayings. And another one mentioned that we like the community engagement focus of the program that helps us find and help others seek solutions to the problems. And this program is inspiring and has changed our vision and goal towards the life. So after training, we are much more confident and we will be able to sustain these health promoting practices, which will significantly impact our community. And the third one is, in the program, we learn different skills to reduce stress, which was simple and easy to teach other community members. And all the exercises are simple and relaxing, which can easily do using pictorial instruction. And this program allowed me to share my knowledge and skills with my families and community members. And then I receive frequent phone calls from the community members even after the program. So I have gained confidence and I'm happy to work for my community. So overall, the community members, they mentioned that they have gained lots of confidence and they have done like a lots of self-esteem and value, not only within the project time, even after the project also, they were sustaining the program based on their learned skills. And we published these findings in the 2 different journals in collaboration with our community collaborators, and one for the group intervention and one for the family-based intervention. So with having this success, then we extended our collaboration to the other refugee community members. And the first, we extended our collaboration with the Ukrainian community, and they also showed big interest to implement this program. And we tailored the components of our intervention for that community, and we implemented this program in this Ukrainian community by recruiting participants from Westfield, Springfield, West Springfield, Chicopee, and some other places also. And we also implemented same 5 sessions of intervention by tailoring their needs. And these are some of the pictures of conducting the session, and especially all the participants, they really enjoyed our session. And I still remember that one participant on the first day, she didn't speak, and on the second day, she told me that, why I'm getting so much stress up to now. So before attending this program, I was so much worried once I wake up in the morning, but after attending the program, now I'm so much excited. I can see so many things I can do that. I'm so much happy, and I have already started joining the classes. And at the same time, I'm also encouraging other members to do more instead of becoming super stressed and depressed. So these are the things I still remember while conducting these sessions. And with the Ukrainian community also, our program showed the wide reduction of anxiety and depression in this population. And we also published these findings in communication with the community collaborators. And regarding the other coping, social support, and social networking also, we found profound significant improvement after the intervention in Ukrainian community as well. So with this, then we extended our intervention in the Afghan community also. In the community also, we implemented same 5 models of intervention by tailoring their needs. And in the second picture, our graduate student, he helped us to translate all the findings in their local language. So with his help, we were so much able to implement the program successfully in these Afghan community settings as well. So these are some of the pictures of our intervention. And our intervention impact is so that this program also greatly helped to reduce the depression, anxiety, and the stress score among Afghan participants. So these are some of the community voices of program benefit, especially just in the summary from that community also. They told us that now they are feeling much more confident to deal with their problem, especially to view the problems by breaking the big problem into small problem, and that they are trying their best to solve the problem by themselves. And even in the staff in the organization also, they told us that before the members, they used to come, even for the small problem also, they used to come and visit the organization for their help, but now they are solving their problem by themselves, not only for themselves only, they are becoming like a model for the newcomers also. When the newcomers come, oh, you can do this, you can do by yourself. So they are developing, they are running sharing all these learning sessions to the new refugee population also. That's the major feedback we receive from the organization. So these are the major findings of the 3 different populations. So after having success in all these pilot studies, then we advance our intervention to the problem management plus for the immigrants by incorporating the one major component like behavior activation in our intervention model. And this is also the preventive model, and this one, we have 4 different components. The first one is psychoeducation, second is problem solving, behavior activation, and the mind-body exercise. And this intervention is guided by the World Health Organization Problem Management Plus Intervention, and we tailor that intervention components for the immigrant population. And this is our framework for the randomized controlled trial to scale up the intervention in the large population. So in this one, we use the screening criteria of Patient Health Questionnaire 9, PHQ-9 questionnaire to screen the participants with depression, because our program main objective is to prevent the mental health burden. So that's why we screened those participants who had the depressive symptoms with a score more than 40. And we just included the participants with without depression in this model. So then we measure all the mental health as well as other social and emotional parameters before assigning them to the intervention and the control group. And after that, we randomly allocated like 58 participants in the intervention group and 58 families in the control group. And we recruited 2 participants from each families for the survey, but all the family members are welcome to join the intervention. And after that, we measure all those parameters after intervention and 3 months post-intervention. And we also collect the stress biomarker, stress here samples to measure the stress biomarker. And for this program also, this program is fully implemented by the trained community members. So for this one, we recruited huge number of the community interventionists for the field supervisor and for the interventionist program. And then we conducted 12 days full training for the community members to deliver the intervention, like 10 days for the intervention components and the 2 days for the supervision. And for the another group one, we recruited as a research assistants, and we trained them to conduct all the surveys to collect the data from the community members. And so 3 group of trained community members, they implemented this trial, they run the trial. So the field supervisor, they supervise all these community members so that the program is on track. And the interventionists, they deliver 5 sessions of intervention to the intervention families, like 58 families. And the control interventionists, they deliver 5 sessions of intervention to the control families. And after that, and then we also train them in the process evaluation, so they can evaluate their peer after the session by doing peer mentoring. And they also did evaluation as well as they collected different components for the intervention fidelity, for example, like adherence to manual intervention content administered, proper use of time and materials, participant engagement, participant acceptability and satisfaction. So they collected this information as well as they supervise each other so that they can deliver the best quality of program to the community members. So we did 3 different types of supervision. The first one is the peer supervision they did on the spot immediately after the intervention. And after that, the field supervisor also, they supervised them. And from our side, we also supervise them by the Zoom interview in every week and by the group discussion. So this is the program impact of our randomized controlled trial. So in the first picture, we can see that the mean score decreased rapidly from the baseline to the post-intervention, and after that, it remains steadily after the post-intervention to the 3-month intervention in the intervention group. Whereas in the control group, the mean score remains almost flattened. There's no change for all the stress, anxiety, and depression. And this is the result of a recent randomized control trial funded by National Institute of Health. And currently, we are writing manuscript on this project. So the basic key learning for us to make our program successful is that the community engagement is so much important, and we need to start from the very early stage of our project, from the need identification, and it is so much important to engage community members in all steps of our research project to make it successful as well as sustainable. And another one is we focus on the preventative strategies. And third one is because of the culturally tailored multi-component intervention design was helpful to address their various needs. So in conclusion, our intervention participants, they reported the significant improvement in the health promoting behaviors and the mental health outcomes across the course of our program among resettled Afghan, Bhutanese, and Ukrainian adults in the Western Massachusetts. So it will be great to replicate and scale up this intervention in the wider population to have much more wider impact in the other community. And so we completed the first 2 different type of project, and after having that, currently we are implementing the healthy aging intervention to the older adult population by tailoring the content of that intervention in the Western Massachusetts, funded by the Department of the Public, and this is our current ongoing project right now. And so I really want to acknowledge the community members and leaders from our community. The first one is our team member from the Bhutanese community. And the second one is from the Ukrainian community, and third one is from the Afghan, and that we are so much grateful and then thankful for their invaluable time, advice, support, and commitment to complete all these projects and to bring some impact in the community members. At the same time, I'm so much happy to mention that especially with the Bhutanese community, because we have started working with them since 2015. So the young girls and boys who have started working with us, now 2 of them already completed nursing program. So they are working as a nurse in the community right now. And then 3 of them now doing nursing study. And 2 of them now they are doing PhD. So those are the young boys and girls who met with 2015. So when we implemented the program, we are not only implementing our program, at the same time we are advocating the importance of education, how much it is important. So because of all those things, we are so much happy to see those trained nurses and those PhD graduates in the community, and they are playing so big role model in the community to inspire other young generation. And finally, I would like to acknowledge all the community members as well as the donors like University of Massachusetts Amherst and National Institute of Health, Community Foundation of Western Massachusetts, Department of Public Health, and Blue Cross and Blue Shield Foundation of Western Massachusetts. And finally, I would like to express my sincere thanks to my team, Board Stress, for all of our support, engagement, and inspiration to complete all these projects. And my research collaborators from our Elaine Merriam College of Nursing, Dr. Cynthia Justin, she's here with me to join. Thank you so much. And from the Department of Psychology and the Brain Science, we have Dr. Maureen Perry Jenkins, Dr. Holly Laws, Dr. Christopher Martel, and then Dr. Gerald Mayer. And from the School of Public Health and Health Science, Dr. Elizabeth R. Burton-Johnson, and Dr. Krishna C. Pudel. And the Pamela Burris, our holistic nurse from our College of Nursing, and all the undergraduate and graduate students of UMass Amherst. And I would also like to express my sincere thanks to Dr. Stephen T. Holland from the Vanderbilt University, and our community collaborator, Caroline Davis from the Ascendia Care Alliance. And finally, I would like to express my very sincere thanks to all of you who are here to share my talk, and thank you so much. And I would like to share more depending on your interest and any question you might have. Thank you so much.
Thank you, Kaplana, for these comments. What I also want to say is when you do this kind of community engaged work, there's a lot of invisible labor that has not been talked about here. Because you can go to your lab and your silica chips you don't need their collaboration and they can't run away. And there's a lot of trust building that needs to happen. There's a lot of travel back and forth, and you're building human relationships. And you probably know that this has been 10 years in the making. So that's the kind of commitment we applaud when you do this work, and it's great to see all this great impact. So now we do have some time for Q&A. I'll let you manage this, and our colleagues will move the mic around, and then they'll give you some heads up when time is there.
Thank you so much.
Kalpana, thank you for the presentation, and it's always great to hear about the incredible work that you've done in the community. I wondered, as you think about next steps and continuing to scale and perhaps affect other parts of the community, have you thought about what the long-term implications of the work are and how you might think about being able to go back to communities to find out kind of beyond the intervention, beyond the 3 months? I know you keep in contact with them, but in a formal way, have you thought about how you might measure that?
Yeah, So that, thank you so much for the such an important question. Right, yeah, that is, yeah, we really wanted to do the long-term follow-up for the intervention in the community, but only we haven't designed in the long-term way only because of shortage of fund. That is the one most important thing, because because community members are already trained, they are equipped in the community, they are ready to work, but it is not, I don't feel comfortable to ask them to do volunteer work all the time, because we are in the United States, all of them, they are so much busy, they need to do the work for their living and they have to study. So they are trained, and informally they are doing lots of supervision during their normal regular program when they meet in their formal and informal settings. And when the community members, when they need some help, they used to reach them and they are helping them informally. But informally we haven't documented yet. So this is also our plan. The main thing is that because of the lack of the funding, we are not able to mobilize the trained people to collect the data quantitatively. But in terms of qualitatively, whenever we go to the community, we are receiving lots of qualitative information by mentioning that after this program, we have received these differences in the community. Just like one, I still remember my field supervisor told us that when the field supervisor used to visit them in the community, before they offered them like a Coke and that type of junk drink, but after the program, they offered them like a water. And even in the grocery store also, grocery store person, he shared his experience by mentioning that before the community members were grouped around all the junk food and that type of things, but after learning the importance of the healthy diet and all those things, now he can see the people are grouping around more in the fresh food. This is like an informal type of feedback we are receiving, but for the documentation we haven't done yet, mainly because of the funding. We already have trained manpower in the community, but we really want to do that also. Yeah, thank you. Yeah, over here.
Kalpana, thank you. It's wonderful to hear about this work. I'm wondering if you could talk a little bit about how you had to tailor your intervention among the 3 or 4 communities you've worked with, because the whole point of this was that it was a culturally sensitive intervention, and these are really different cultures. So I'd like to hear about that.
Yeah. Thank you so much. Yeah, especially for the cultural tailoring, the starting point of that intervention is when I went to the community and when I was interacting with the lots of community members, the one remark given by one member that really struck me first to design the intervention, and then he mentioned that we are in US, we have lots of facilities. When we are sick, we can go to the hospitals and we have treatment, we have counseling, all those things, but main important thing is we don't want to be sick. So could you please share some of the ways what we can do from our own capacity so that we don't need to be sick and we don't need to go through all the process. So that's the striking thing for me to design this preventive intervention at the very early beginning of the project. And after that, we went through and interacting with the community members, and most of the time we talk with them and we explore their ideas on what might be best for them by sharing their experiences, and we gather their thoughts, and we finalize from that gathered containers what would be the best to include in our main audiovisual materials like that. And for this one, when I think about the 3 different groups, like especially in the Buddhist community, they really like talking rather than reading, and they like talking and they want to share their experiences, and they do lots of activities together in the Buddhist community. But in Ukraine, I find that they also enjoy reading the materials and looking the stuff, that type of things. And in the Afghan community, we found that especially in the female group, we found that they really want to explore more with the female trainers and with the female participants at the beginning. But we had a very nice experience. Like in the first 2 sessions, we had that type of, like one day I went and interacted with them and learned about that, but after the 3rd session, they became so much open and they welcome everyone to join the session, and even they were welcome to take the pictures and share their pictures in the forum. And so while seeing the differences, the common thing is that all those 3 communities, they like talking and they like interacting more in person to share their feelings and thought and to like doing the activities. That's the common thing. But the way of doing is a little bit different in all those 3 communities. That's the differences I noticed. But in general, those 3 communities, I found the similarities like that. Yeah.
Thank you so much for the excellent talk. My question was related to, like scalability, like considering all that you mentioned. This is culturally sensitive, or even it has to be tailored to the needs of the population. So I was wondering, like, if you do want to scale it up, like what kind of programs or policies do you think could sort of help this, which sort of maintains the, the part of tailoring it, but at the same time, like you mentioned, there's a lot of resources needed in training people and the time that they spend in all of this. Like, what is that thing that's needed to make this happen?
Yeah. Thank you so much. Thank you so much for this important question. So one example I would like to give up about when we are replicating and scaling up the intervention in the new population, just like currently we are implementing the healthy aging intervention. So in this intervention based on the older adult population, we incorporate a new component on the self-management of chronic disease, what they can do in their household levels to maintain their blood pressure, like salt intake, diet, and exercises, that one. Another one, we incorporated like health-seeking behavior. When they visit the healthcare provider, what are the things they can prepare so that they can best minimize their time when they are seeking, when they are talking with their healthcare provider. We made the format developed by National Institute of Health. So the participant, before going to the healthcare provider, they are preparing what are the 3 important health needs or health concerns they want to discuss, what are the medicine they are taking, and what are the other consequences they want to talk. So they are preparing that type of format for the health-seeking behavior. And another one is we incorporated like the safety, like injury prevention, especially for the older adult, because in their home setting, because at the night when they wake up, and because all the things are scattered in the room, and once they wake up from the bed and from their bed to the restroom, they are more likely to fall. So we incorporate that type of home safety measurement also in our healthy aging intervention, so that at least they can clean up their room and their pathways so that they can be safe in their home environment. Those are the 3 components we have incorporated for the healthy aging. So back to your question about what might be needed to make this intervention more sustainable or more applicable at the policy level, is that just ours is like a behavioral intervention. So there are lots of social determinants of health that are impacting the refugees, and not only refugees, and everybody's health. So it is not possible to address all those needs by one intervention. So it is so much important to work like a multi-sectoral collaboration, like in collaboration with different sectors like education, agriculture, engineering, health, and public health, so that if you can jointly develop some intervention by working together to address the various social determinants of health, then that will be more visible at the national level to bring some changes at the policy level. So this is the work that we have just started together with the Chaitra. That's why she raised me that question. Currently, we are working on that component also, how we can jointly work together so that we can address the social determinants of health of the refugee population, not only for the behavioral components, but also from the environmental aspect as well as from the policy level. So currently we are working on that part. Thank you so much.
On behalf of Chancellor Reyes, it's my distinct pleasure to present you with the Chancellor's Medal, the highest award that this campus can bestow on our faculty. Congratulations.